I'm Dr. Prof Lonial, and we're here live with eCancer News at the 15th International Myeloma Workshop in Rome. And I'm joined by my colleagues, Dr. Sonneveld and Dr. San Miguel, and we're going to talk a little bit about some of the highlights from the meeting today. So let's get started talking a little bit about the one area that I know people are really excited about, and that's monoclonal antibodies. We've got at least two that are potentially imminently approvable. And I think the mechanisms of action are actually quite unique and multifactorial, not just enhancement of immune function, but also ADCP potentially, CDC, and even direct cytotoxic effect through binding and interaction with CD38, for instance. What do we know about their activity as single agents and in combination?
Okay, regarding single agent, elotuzumab has not shown activity as single agent, only stable diseases, but in combination with lenalidomide, we have already the data of a large randomized trial showing superiority. As far as anti-CD38 monoclonal antibodies is concerned, as single agent, they have clear activity. Approximately 1/3 of patients that has been refractory to all previous treatment have responded to the anti-CD38 monoclonal antibodies. The most mature data correspond to daratumumab, but there is also similar data now with SAR and another monoclonal antibody.
And what about combinations? What do we know about trying to make these drugs even better?
Well, combinations with, as was mentioned, with Len-Dex, for example, but also with the proteasome inhibitors, they seem very promising. Right now, there are studies ongoing or have already been completed, like Castor and Pollux, with either the IMiD or the proteasome inhibitor, that we have to wait for the results. But well, the results that we know of preliminary are very promising. And there are trials now planned or ongoing in the newly diagnosed patient that will also explore these combinations of proteasome inhibitors plus an IMiD plus daratumumab. Right. And for elotuzumab, the same thing.
Right, right. I think it's really exciting. So I think our centers have probably treated a lot of patients with each of these antibodies. What are the unique pitfalls or classical antibody-related things that practitioners need to be aware of as they get out there?
Okay, probably the first one is the infusion reactions.
Right.
Approximately 2/3, if not more, of the patients have infusion reaction. The good news is that they are mild, only grade 1, 2, and they are well controlled if you premedicate appropriately these patients. A second problem, it could be the interference that you may have with the monoclonal antibody when you assess the response, because the monoclonal antibody may give you a false band in the electrophoresis that may confuse as a residual paraprotein. And also you can have problems with the red blood cell when you are doing the typing for a transfusion due to the monoclonal antibody. But we have learned already, I think, quite fast how to handle these problems.
Yeah, yeah. Anything you want to?
Well, those are practical problems, and people have to be aware of it. So if you don't do the blood typing before giving daratumumab, you have to rely later on genotyping rather than phenotyping.
Right. Right.
Another thing I would like to mention is that with daratumumab, it's of course important what the CD38 expression on the target cell is, in this case the myeloma cell. There are myelomas that have a lower or even low expression of CD38, and what people in the lab have discovered is that you can increase the expression of CD38 in the tumor cell by treating the cells with ATRA, so all-trans retinoic acid. And this seems also a promising way to improve the efficacy of daratumumab. We will start a trial shortly where patients will have daratumumab monotherapy and then later on with ATRA pre-treatment, and we look at the expression of CD38 and the cell killing. So this is...
yeah, really amazing laboratory data that really identified that. And that coupled with the data, I think from the same group that also suggested that expression is directly linked to response, really speaks to things that try and upregulate CD38 expression.
Exactly, so that's an important issue.
Yeah, yeah, okay. Well, let's switch gears a little bit and talk about the new proteasome inhibitors. We've talked about lots of different ways to give bortezomib IV sub-Q weekly, twice weekly, but what do we know about the right way to give carflizomib, and what else is new on the front in terms of oral proteasome inhibitors?
If I may start with carflizomib, this is a very effective and potent proteasome inhibitor. We have used it in both relapse patients as in a trial for newly diagnosed patients. It's well tolerated. It's rapidly effective. And so far we have not entered major problems with the administration. So it can be done on an outpatient basis. And patients tolerate well, up to 6 or 8 cycles of carflizomib in combination with 1 or 2 other drugs quite well. So both with Lendex or with Taldex we have seen good results and minor toxicity.
Tell me about the concerns that certainly float out there about heart failure, cardiac issues, shortness of breath. Have you found that in the phase 3 trials that you've run to be an issue?
Well, it's definitely an issue. I think we should not underestimate this because the cardiac effects may occur suddenly and unexpectedly in patients. So you have to monitor your patients, you have to check them for pre-existing cardiac disease. I can say that in the carflizomib Taldex trial that we did in 120 patients so far, newly diagnosed patients, we have 2 cases where patients developed cardiac problems. One was a patient already with cardiac disease and the other was new. So we keep an open eye for it because it's not frequent, but if it occurs, it's serious.
And what do you think, both of you have had experience looking at 2036, 2056, once a week, twice a week. What do you think we're going to end up using in real practice?
I think we are looking forward for the once a week, for convenience for the patient. And in fact, there is an ongoing trial that will try to answer this question. But for convenience for the patient will be much better the once a week if the activity is preserved.
Okay. Okay.
I agree, yes. Definitely.
And ixazomib, tell us about the oral proteasome inhibitors.
Yeah, the ixazomib is the twin brother of bortezomib. The advantage is that it's not only oral, but also the incidence of peripheral neuropathy is significantly lower as compared with bortezomib. It has shown efficacy as single agent, even in bortezomib refractory patients, and in combination with Lendex, we have already a phase 2 trial showing a high activity, not only during the combination, but also as part of the maintenance, increasing the quality, the depth of response. And probably this is the rationale why so rapidly several randomized trials, the Tourmaline project trials, has been activated in combination with Lendex. More than 700 patients in each of the trials that are currently being conducted in combination with Lendex in newly diagnosed patients and in the relapse setting, and as maintenance after transplant and also after conventional induction for the elderly patients not candidate to transplant. Then probably we will have soon data on this very important randomized trials.
Yeah, I mean, I think it's really interesting, especially the maintenance aspect, I think could really make things a lot more convenient.
Yeah.
So I'm going to ask the provocative question. In induction therapy, if you've got great second generation proteasome inhibitors and you've got great IMiDs, where are the alkylators gone from induction? Not transplant, just from induction.
Well, I think we have learned that the alkylator, say melphalan, is not a good partner for lenalidomide. Look at the MPR studies. Now that Len has been established as a solid first-line treatment, Lendex for patients, especially the non-transplant eligible patients, I think alkylator is not the first choice anymore. So combinations of an IMiD with steroids and possibly also an oral proteasome inhibitor is probably the future.
Okay, although I will accept this, I'm not so convinced.
I knew you wouldn't agree on this.
No. As you know, I am really a big supporter of melphalan because I think this was the first drug that demonstrated clear activity in myeloma. And in fact, the data that we have when we compare VTP versus VMP and the non-transplant candidate showed that although in the short term the responses were higher with VTP, the long-term follow-up, the survival was better. And we should not forget that melphalan, as all other alkylators, may target precursor cells that may translate into prolonged survival, and it's a cheap drug, which is very important.
Yes. No, I'm not saying that melphalan should be deleted from every treatment, but your VMP versus VTP was with, let's say, older drugs.
Oh, yes.
Thalidomide is older.
Right.
Yeah.
Now we have the lenalidomide IMiD, which is better than thalidomide. We have the oral proteasome inhibitor. I think this is the way most investigators think this has to be explored.
No doubt. But
Yeah. All right, the controversy will continue.
yeah.
So let's switch to HDACs. This has been an area where we've started and stopped and started and stopped. We were all excited about Panorama 1, and then everybody started criticizing the difference in PFS. But I think we've had some new data in the last 6 months, or new reviews of the data, that have really identified who the better patient populations may be.
Yeah, I think, and this was very interesting observation that has been presented at ASCO and here also in this meeting, showing that in patients that have received 2 or more lines of therapy and has been previously exposed both to proteasome inhibitor and IMiD, lenalidomide, the difference in PFS is almost 8 months because the response when you have the panovinostat is maintained and the PFS is maintained while in the control arm is significantly lower. Then I think this is very important news also for the and this was the basis for the approval both by FDA and EMEA in this cohort of patients.
Yeah, I mean, I've been really struck by the ability of the HDACs to overcome either active drug resistance or emerging drug resistance. And the patients that seemed to gain the most benefit from Panorama 1 were exposed to an IMiD, exposed to a PI, and had 2 prior lines of therapy. So those are patients you could argue are well on their way to drug resistance. And so that's where we saw the biggest bang.
In addition, I fully agree with what you say. In addition, there are now also selective HDAC6 inhibitors that show great promise in the lab and also in early trials in relapsed refractory patients. So
and excellent tolerability, which is important.
Right. I think ricolinostat certainly fits that bill. The ability to be selective for HDAC6, not specific, because I think too specific may be a problem as well. But its combination attributes, both with proteasome inhibitors and with IMiDs, is really quite striking as well. So let's talk a little bit about genomics and updates to new methods of MRD assessment. I know you gave a really nice talk today about some of this. How does that fit in with where we're going?
Well, I think the most myeloma doctors now agree that genetics, genomics play a role in the prognosis of patients. I mean, this is something that we learned from leukemia. So FISH is now more or less established, but there are next steps ahead, like a more broader interpretation of the genetic data of the biology of myeloma, for example, by using newer techniques like gene expression or genome sequencing. And these will learn we will learn from those results how the biology of the myeloma, how it works into the prognosis ultimately, and also if we can predict the response to specific drugs based on the biology of the myeloma. So this is important. In addition, MRD is another important prognostic analysis and test that can be done somewhere after initial treatment, maybe after induction or after the transplant or after the end of maintenance treatment. I think we still have to learn what's the best moment, whether it's a split-second analysis or a more continued analysis. There are trials ongoing where this will be analyzed, and for the moment I would like to say that it looks like MRD assessment is important for prognosis. You can identify patients with remaining tumor load, they are MRD plus. Patients where you cannot identify surviving cells, MRD negative. And the key question now is which method should we use? Is it flow cytometry or exome sequencing? So it's important that both techniques will be incorporated in clinical trials so that they can be compared and that we know, hopefully, in a few years, which is the method to use.
Yeah, I mean, I think, to me, that message is really the key one, which is, I think we're in the learning phase of what to do. We're accumulating the data. I'm not sure I know what to do with somebody who's MRD positive at 2 years out from an autotransplant, who's otherwise fine, or who's 2 years negative out from an autotransplant, who's MRD negative and doing fine as well. I don't know, do you all feel like we have the data to make treatment decisions based on that information yet?
No. Unfortunately, we have not yet this data. And this is, I think, a learning curve similar to what has been done in ALL.
Yeah.
I think ALL is a model for many things, and one is how to use appropriately minimal residual disease. We are using continuous treatment. Is needed for everyone. Minimal residual disease probably can contribute to this. We have already identified a group of patients, those with high-risk cytogenetics, that after transplant are MRD positive. This patient has hopeful prognosis. We already, for these patients, do immediately, they have minimal residual disease positive, we do something else. But apart from this category of the patient, for the rest, I think we need, yes, to conduct prospective clinical trials, including MRD.
Yeah, this is what has been lacking so far. Yeah. Trials specifically designed to answer the question, what does it mean MRD positive or negative? What if you apply regimen A or regimen B to those situations?
Yeah. Okay, so as we're wrapping up, let's touch on the new definitions of myeloma and perhaps the new staging system.
We have recently created guidelines in which for treatment of myeloma, you not only will have the CRAB criteria, but also if you have more than 60% plasma cell without CRAB, or a free light chain ratio of more than 100 without CRAB, or more than one focal lesion on MRI. This is active myeloma because the risk of transformation is more than 80%, and these are clear candidates for active treatment.
Right. It's a big change, but I think it's well needed.
Yeah.
And do you want to touch a little bit on the revised international staging system?
Yeah, I think that's also a major step forward. So rather than using one prognostic parameter like cytogenetic abnormalities or ISS, now we know that combining those and other parameters like LDH and age, for example, that they may significantly improve the prognostic impact of those staging systems. And recently IMWG has made a big effort to combine the data from a lot of trials, and based on that the revised ISS was constructed. But there are also other examples before that show the same picture. So by combining clinical factors with genetics and age, we will be able to better classify the patients into all the range from good to standard to low risk.
Yeah, I think it's really an important paper to look at because the new staging is not just two numbers anymore. It really does take a little bit of time to learn it, and I think you're right, incorporating genetics is really makes it a more modern staging system. Yeah. All right, well thank you. It's been a great meeting.
Thank you very much.
And thank you for tuning in to eCancerTV. We hope you've enjoyed this session and look forward to additional sessions at future meetings down the road. Thank you.